Hello, WM community around the world. Welcome to day one of the 26th annual IWMF Educational Forum. What an honor to kick off the very first session of our month-long educational extravaganza. Can you feel the excitement? I am Lisa Wise, and I've had WM for the past 11 years. During that time, the IWMF community has been my support, my lifeline, and my extended family. I'm proud to be a volunteer trustee and vice chair of information and support, as well as the Philly support group co-leader. Thank you all for teaching me every day how to live fully and thrive with our weird and wacky chronic illness. Now, let's get the ball rolling. What a sheer delight to introduce the incomparable Dr. Jeffrey Matous from Colorado Blood Cancer Institute. Dr. Matous is a WM rockstar expert who treats scores of WM patients and also co-chairs the International WM Consensus Panel Committee. Dr. Matous is a very good friend of the IWMF. Please check out his bio, which is one of the helpful resources accompanying today's talk. But let me share a little insider fun fact before we begin. Do you know that his true passion is America's national pastime? Dr. Matous is not just an extreme fan, he is a baseball connoisseur. When my kids were little, they were fascinated by the closer, the pitcher who ended the game. But through the years, I have learned that the real star is the opener. The starting pitcher who sets up the whole game by laying out the foundation and covering all the bases while making sure everyone, even in the cheap seats, appreciates those fastballs while also allowing time for us extra slow runners, which is me. Who better to have as our opener than our beloved Dr. Matous, who will kick off this year's Ed Forum as he presents on the topic WM and basic terminology. In addition to summarizing WM basics, he'll offer explanations of diagnosis, symptoms, and simple treatment guidelines. After his slide presentation, we're going to enjoy a fun Q&A session, so stick around for the post-game tailgate party. We hope you all have your snacks ready, maybe peanuts and Cracker Jacks. Enjoy the presentation, and over to you, Dr. Matous. Play ball.
Thank you so much, Lisa. I hope I got my good stuff today and don't get knocked out of the game too early by some big hitters. Anyway, it's always a pleasure to speak to the WMers, and I really enjoy just sort of setting the table for everything that you're going to hear after my talk, because the really big players come on after me. So I've been tasked with describing some basic terminology for WM. I think this is really important, because one of the real challenges when you're a patient is when the doctors get going and they get talking a whole bunch and using big words and big terminology, is to say, what language is this even? So I'm going to try to make it so you can understand the language that comes out of doctors' mouths when they're talking to you about WM. So what are our objectives today? Well, again, to make everything related to your WM diagnosis as understandable as possible. And like I said before, to develop some fluency and be able to understand what on earth the doctor is saying during your visit. And also to develop a solid base for following the rest of the educational forum, especially when Dr. Castillo starts showing data slides. You're going to need to know this talk. So what is Waldenstrom macroglobulinemia? That's why I call it WM. And why do we call it that? Well, WM is a rare, very specific type of blood cancer. It's a type of cancer called lymphoma, more precisely a non-Hodgkin lymphoma. And in contradistinction, there is actually a Hodgkin lymphoma. Non-Hodgkin lymphomas are far more common. This specific kind of non-Hodgkin lymphoma is called lymphoplasmacytic lymphoma. And often we refer to it, and it's referred to in the literature and in publications, as LPL for lymphoplasmacytic lymphoma. The macroglobulinemia part refers to a very large type of protein that's part of our immune system called an immunoglobulin. And it's made by the abnormal lymphoma cells, and this protein is called IgM. So this disease is named after, appropriately, Dr. John Waldenstrom. He was a Swedish physician. He died in 1996. And besides WM, he made an incredible number of very important medical discoveries. And so he's quite a talented physician scientist. He described WM in 1944. And those of us that do WM for a living, we take care of a lot of patients with monoclonal gammopathies. These are diseases associated with abnormal proteins. And he described that as well in 1961. So in our field, in our eyes, he's an absolute giant. So I talked about the fact that your lymphoma, WM, is a non-Hodgkin lymphoma. And there are many kinds of non-Hodgkin lymphomas. In fact, dozens of these. And this is a slide summarizing many of them or most of them. And you can look here in the upper right, we talk about mature B-cell lymphomas, and some of those are very aggressive. If you go to the bottom left corner, you look in the indolent. Indolent's a word that we use in our field for slower growing lymphomas. You see WM buried there between a bunch of the other lymphomas. And just to let you know how unusual your lymphoma is, you have a 3 in a million lymphoma. And so you're in a rare group indeed. So how do we define WM? Well, WM is very specifically defined. And in order to make a diagnosis of WM, we need to have both these abnormal LPL cells found in the bone marrow. So you cannot make this diagnosis without examining the bone marrow. And finding also this abnormal IgM protein in the blood. And on the right side of my slide, I've put diagrams of 5 different immunoglobulin proteins that are part of our immune system. And what you can see is that the IgM protein is not like the others. In fact, the IgM protein is made up of 5 of these different proteins all bound together. And so that it's a very, very large protein. And this becomes a problem for some patients with WM because this protein is so big that if you get a lot of it in your blood, it can impair the proper circulation of the blood in your body. And we have a term for that we'll talk about a little bit later called hyperviscosity. And so that's the reason that the WM patients get hyperviscosity, and patients who have problems with the other immunoglobulins rarely, if ever, do, is because of the large size of the IgM protein. So let's talk some more about how we diagnose WM. And so some patients with WM get diagnosed as a complete surprise. And I call this an incidentaloma. You're minding your own business, you go to the doctor, they draw your blood, and usually what happens is they notice on a chemistry test that your total protein is elevated on your chemistry test, and then they go, and then they do some other tests that we'll talk about in a minute, and then next thing you know, you're in front of the hematologist oncologist. Other patients have symptoms, and we'll talk about what those are later. Now, the routine blood work can lead to clues that WM is present, and for symptomatic patients, the blood test can lead to an accurate diagnosis and assess in what manner the WM might be affecting the patient. So let's take a minute and review some of the important blood tests that we use to make a diagnosis of WM. So a very important test is called the complete blood count, or CBC. This is drawn up in one of those tubes that has a little lavender cap on top of it. And when we get a CBC, we actually take the blood and we run it through a machine, and then we also look at it under a microscope. And what we can see, as in this slide, is that blood is made up of 3 kinds of cells. They're suspended in a solution called plasma. And in the large arrow here, you see these red cells. They look like little discs, little car tires, and they're the most common cell that we see in our blood. These are the red blood cells. They carry oxygen. The white blood cells there are several different types of white blood cells. And here in this slide, you can see, in fact, 5 different types of white blood cells, and they all have specialized names. And so where the red cells are all pretty much the same guy, our white count is a mix of different kinds of white cells. And then we have small cells that look like little dust specks here. I didn't see any on this slide, called the platelets, and they clot the blood. Now, when you look at your CBC, you'll see some other specialized tests. And one that we look at a lot is called the MCV. It reflects the size of the red blood cells. And for those of you who are really curious about how we use that in WM, if the MCV is low, the red cells are small, that may suggest iron deficiency, which is actually more common in WM patients than in the general population. And alternatively, if the MCV is high, that means the red blood cells are larger, and we can see larger red blood cells in WM if you have a rare complication of WM called hemolysis, where you chew up your red cells a little bit too quickly and too early. And then we have a test called retic count that we can also run on here that measures how efficiently your bone marrow is producing red blood cells. So this is the CBC. Now, what does the CBC look like when you actually get one back here? This is a real CBC result, and you get all this stuff on here. And what's tough for patients is when anything is highlighted and alerted as low or high, and when some of the things get flagged as low or high, we really don't ever look at, but some of them we do. So let's look at this CBC. We can see here is that the white blood count is a little bit on the low side of 2.3. And usually when you get a CBC, it gives you your result. If you look over here, it gives the normal reference range. So a normal CBC, I always say, is ballpark 4 to 10. And this person's CBC is a little bit low. These next three tests here measure the red blood cells. And most doctors will look at either the hemoglobin or the hematocrit. We usually don't spend too much time looking at the RBC. And again, you can see here, this person has a low hemoglobin, a low hematocrit. And just for those of you who are interested, usually the hematocrit is roughly 3 times the hemoglobin. And we can tell that this person has a low red count. We call that anemia. Here's the MCV. That refers to the size of the red cells. And then the rest of this stuff here, I don't spend much time looking at. I don't encourage my patients to look at it. Here's the platelet count. And a really, really important test when you're being treated with any chemotherapy type agent is to be aware of a test called your neutrophil count. Recall in the slide before that we said the white count is made up of different types of white cells. Well, you can see here, this is a total white count that's 2.3, made up of individual types of white cells that are summarized here. And they have names like neutrophils, lymphocytes, monocytes, etc. And the neutrophils are the primary infection fighting cells. And so you want to always keep an eye on those. In some WM patients, if they have a fair amount of WM in their bone marrow, that LPL stuff in their bone marrow, those lymphoma cells will actually leave the bone marrow and circulate in the bloodstream. And if that's the case, then this test called the lymphocyte count will be high. So this patient has a slightly low white count, slightly low neutrophil count, and a little bit of anemia. We also do a chemistry profile. And this is how most of you get discovered to have WM when you don't have symptoms. And we see there's a lot of information here that's on the chemistry test. We can see kidney function, that's the creatinine test. We can look at the calcium. We can look at the liver blood test. We can see how electrolytes like potassium and magnesium are. And the most important thing we see in WM is we can see that the total protein level can be elevated. So here's an example of a chemistry test. Lots of stuff on here. And what you really need to pay attention to is make sure that your kidneys are nice and healthy. And this is the creatinine test that measures how well your kidneys are doing their job. And that's anything ballpark of 1 is great. And then the total protein is often elevated in WM. Now, why is that the case? Because the IgM level is included in that total protein number. So if a patient has a high IgM number, it'll be reflected in the total protein number. And this is usually the test that gets the internal medicine or family doc's attention. Then they do a confirmatory test that we'll show in a second here called an SPEP. And then next thing you know, you're in front of the hematology oncology doc. So what other tests are important for WM? Well, measuring the IgM protein, and we can do that directly. There are other ways of measuring the IgM protein. One way is called the M-spike. And then there's a very important test called SPEP, or electrophoresis, that we do when we're making a diagnosis of WM. And then if we're worried that the patient may have the thick blood from all that big protein in the serum, then we can measure a serum viscosity. That has to be ordered specifically. Serum viscosity is not part of any routine blood test. It needs a separate checkbox in order. And for viscosity, a higher level is thicker. And one thing that's important to remember is even if the blood test says your blood is too viscous, you have hyperviscosity, you may have no symptoms. So when we diagnose hyperviscosity in a patient, we're looking for what's called hyperviscosity syndrome. That's a clinical diagnosis that we make when we think the patient is being harmed by the thick blood. There are people who have thick blood who aren't being harmed at all. And so they still have hyperviscosity, but they don't have hyperviscosity syndrome. So what's an M spike? Well, an M spike is another way to measure the IgM. And M stands for monoclonal. That means all the IgM is produced by those clones of LPL cells in the bone marrow. Normally, we don't have an M spike. So in a normal situation, you don't have an M spike. So the normal result is 0. But if you have clones of cells that make a monoclonal protein, like WM patients, then you typically have an M spike. And we can follow that M spike and or track the IgM level to see how the WM is behaving in our patients. Usually, but not always, the higher levels of IgM or the M spike mean there's more WM, and lower levels mean there's less WM, but this isn't always true, and results with IgM and M spikes can vary greatly between patients. So how do we track our disease with our special tests? So this is not a chemistry test. This is not a complete blood count. This is a special test called SPEP that we use to track our patients with WM. The top one's called SPEP. The bottom one is called quantitative immunoglobulins. These are tests we always use in our WMers. So this patient has an M spike of 1.8 grams. The normal result is we don't see it. This patient has an elevated level of IgM in their blood of 2849. Here's the normal range over here. And often what happens when the IgM level is high is that the IgA levels and the IgG levels are low. That's pretty common to see. And many of you may have remarked on that when you've seen your laboratory results. So this is a real SPEP. This is what an SPEP looks like. And sometimes when you get your laboratory results back or you look at your labs on your portal, you can see this actual picture here. And this is a normal SPEP. So this won't be you guys unless you're in remission. So normal SPEP shows a bunch of different proteins and albumin, and it's different proteins in all these areas. But this is the Greek letter gamma. And this is where the M spike is seen. So if there's a lot of IgM in a patient, this is where you see the M spike. And here's another way of looking at that. And this is where this is an example of an M spike in someone. Normally this is nice and flat like this. And when somebody has a lot of IgM around in the Waldenstrom situation, you get this thing called the M spike. So again, to go back, to properly diagnose WM, we need a bone marrow biopsy. It must be done for the diagnosis. It has to show this lymphoma called LPL, and we have to find monoclonal IgM in the blood. Those two things are required to diagnose WM. In newly diagnosed patients, very often now we test for, there's a different test, an additional test that we use, and it's called looking for genetic mutations. And the most common one in the LPL cells is called MYD88, also called MYD88. And sometimes there's a less common one that we find, and sometimes we don't test for it as frequently, called CXCR4. And these are important things that we're going to talk about shortly. In WM, there's some other blood tests that we do looking for infrequent complications of WM. And these have names like cryoglobulins. And that's a condition where cooler temperatures cause the blood flow to the kidneys or other tissues to be reduced and can damage those organs. There's also something called cold agglutinins. That's a very unusual complication of WM, where the immune system actually gets confused and reacts against your red blood cells and Pac-Mans them or destroys them. That's called hemolysis. And that happens at cooler temperatures as well. So some tests that we have look for a rare complication known as amyloid. And an amyloid is an unusual complication. And for those of you who are interested, Dr. Gertz and Dr. Merlini have written phenomenal amyloid articles in The Torch that I would refer you to get more information about that. It's beyond really what I can talk about in my time today. Sometimes people with WM have excessive bleeding, and they may have something called acquired von Willebrand's disease. There's tests we can do for that. And some of our WM patients, or even patients who don't have WM but have IgM problems, can get neuropathy, irritation of our nerves, and we have tests we can do for that. So the standard tests are done, and then if we're suspicious of other things, or if we're WM doctors, we do a bunch of other tests as well to make sure we understand how the WM is affecting our patients. Critical thing. WM occurs in phases. It starts off as something called IgM-MGUS, then goes through a smoldering phase in some patients, and then in some patients goes into an active or symptomatic phase. So how do we define MGUS, and what on earth does MGUS stand for? MGUS stands for monoclonal, that's the IgM, gammopathy of undetermined significance. To make this diagnosis, we need an IgM level an M spike less than 3. On the bone marrow biopsy, we need fewer than 10% lymphoma cells, those LPL cells in the marrow, and our patients cannot be bothered by this at all to diagnose IgM-MGUS. So no anemia, no fevers, no drenching sweats, no big lymph glands. And people who have IgM-MGUS have roughly a 2% chance per year of developing symptomatic, usually Waldenstrom's. On the right hand of the slide, we have something called smoldering. So some of the MGUS patients will go through a smoldering phase. To diagnose a smoldering WM, we have to have a higher M spike, usually above 3, or more than 10% cells in the marrow, but still no symptoms. No symptoms, the patient's not bothered. And there's about a 10% chance for these patients per year of getting symptoms. Symptomatic Waldenstrom's is exactly that. So when people come in, they say, hey, something's wrong, doc. Or the doc says, hey, you have anemia. This WM is bothering you, it's harming you, and we need to fix it. So by definition, we treat symptomatic Waldenstrom's. What are some of these symptoms or problems that we treat? Well, probably the most common ones are anemia and fatigue. Remember, anemia is a low red blood count, and fatigue. Those are the most common reasons that I start treatment in my WM patients. However, you can also see fevers, drenching sweats, weight loss, neuropathy, hyperviscosity symptoms, that thing called amyloidosis, cold agglutinins or cryoglobulins, and large lymph glands or spleen, or kidney damage. These are just some reasons that we initiate therapy in our patients with WM. So if someone does have hyperviscosity, where they're symptomatic from the blood being too thick and not flowing well, they get nosebleeds, maybe blurry vision, maybe shortness of breath or headaches, then very often what we'll do as a short-term mechanism to help the patient feel better is a test called plasmapheresis. So you may hear this term plasmapheresis throughout the educational forum. And this is a procedure where you literally sit in a lazy boy recliner and have an IV put in each arm, and then your blood is processed in this machine, and then we remove a lot of the IgM that's into that plasma. And what this does is usually makes patients feel pretty darn better quickly, but it's not a treatment. It's really just a way to temporize things and get things better until we intervene with more definitive WM treatment. But this is plasmapheresis. There's a thing you may run into and hear during the educational forum called Bingneal Syndrome. And fortunately, this is quite rare. This is a rare complication of WM where the actual lymphoma cells get into the nervous system, and they can get along the spinal cord or along the brain. And on this MRI here, the part of the MRI that you see that's kind of lopsided in the middle panel B, and on the other side, on the one called C, that stuff that's really bright there represents the lymphoma irritating the brain tissue. So this is called Bingneal Syndrome. You'll hear about this. The other thing you'll hear a lot about, and you'll hear about it from scientists who really worked on this from the ground up and really know it inside out, are these mutations in WM. And we're talking about genetic mutations. These are changes inside our DNA in the blood cells. You were not born with these. These occurred by chance they occur by chance through our lifetime, and we cannot pass them on. These are somatic mutations. These are not ones that you're born with. In a WM, the two most important ones are MYD88 or MYD88 and CXCR4. And what we've learned over the past several years is that these mutations can influence how the WM even behaves. And we can even describe different types of WM, believe it or not, based on these mutations. And also these mutations can influence the treatments that we choose and how these treatments work. So MYD88 is almost always one specific mutation. You'll also see it referred to on your pathology report as L265P. And it's present in over 90 to 95% of WM patients. And I would say these days it's pretty routinely tested for when you have your bone marrow biopsy. The second mutation, called CXCR4, is way more complicated. There are many, many, many different kinds of CXCR4 genetic mutations. And these different mutations can sometimes be associated with different clinical behaviors. The testing for these mutations is more challenging. It's getting better. And I think this testing is being done more frequently these days. And so be aware of both of these. Now we're going to spend a few slides talking about what I call Oncospeak. This is that high language used by physicians in an effort to confuse our patients as much as possible. And you need to know some of this. And so what are some of these Oncospeak words that we use. Well, let's talk about mutations. So mutations, you hear people talk about wild type. What on earth is wild type? Wild type means unmutated. The gene is as it always has been. That's unmutated or wild type. And it's the opposite of mutated. And so mutated means there is a genetic change in the DNA of your LPL lymphoma cells. And so you'll hear about these terms applied to MYD88 and CXCR4. Just to make things a little more complicated, we sometimes call mutated CXCR4 WIM. You'll probably hear that. And sometimes we call mutated MYD88 is L265P. And regarding those mutations in CXCR4, there are different kinds of mutations that you might hear about. One is called nonsense, one is called frame shift. Just so when you hear this language, it's all refers to mutations in the DNA of the LPL cells. So looking here, remember I said sometimes we can look at these mutations and say, well, you know, this WM patient might be different from that WM patient. So how do we do that? So we have something called genotypic abnormalities, and that's what the DNA says. Then we have phenotypic. And phenotypic is how it behaves in the actual patient. So let's look at this first column here. It says MYD88, and here's the mutated. It says L265P, that's mutated. And CXCR4 wild type, that means the CXCR4 is not mutated. And so what we see is this is the most common kind of WM. About 60% of WM patients, often referred to as mutated / wild type. And these patients have pretty decent levels of IgM and marrow involvement with their LPL, and they're very sensitive to treatment using BTK inhibitors. And BTK inhibitors are the IBs, so ibrutinibs, zanubrutinibs, acalabrutinibs. Now let's go over here and find someone who's got a MYD88 mutation, but they also have a nonsense WIM mutation in CXCR4. These patients have very high levels of IgM in their blood, very high involvement of the LPL in the marrow. The BTK inhibitors don't work as well in them, and it's less common. And very, very, very rarely, and whenever I see this, I always question the diagnosis. There are some WM patients who don't have an MYD88 mutation. They're wild type, and they don't have a CXCR4. They're wild type. It's quite rare. The BTK inhibitors don't work at all, and their IgM levels tend to be pretty darn low. And so I'll give you an example. I have a patient who I follow who had an IgM level that was off the charts and diagnosed outside in some other state, in some other place, and moved to Colorado. And the testing that was done said, we couldn't find an MYD88 mutation in this patient. And I said, I don't think the test was done well, because that would be so unusual to see that situation. So this is how we use this information more and more in the WM world. Let's talk about treatment a little bit. You're going to hear from the experts that follow me about the specifics of treatment. So I'll do some general concepts for you here for treatment. One thing is we only treat patients with symptoms. We do not treat asymptomatic patients or patients who are not being harmed by their WM. We have many tools in our treatment toolbox. We have monoclonal antibodies, and Rituxan is an example of that. We have the BTK inhibitors, the IBs, ibrutinib, zanubrutinib, acalabrutinib. We also have old school chemo drugs that we still use, like cyclophosphamide, Cytoxan. And then we have more traditional chemo drugs like bendamustine or bortezomib, Velcade, that we use frequently in WM as well. Now, and then there are other things, of course, beyond this little list here. Now, for treatment, when I talk to patients, I always say, look, we have different treatments we can use. We have some where we usually give you a pill, and that can go on for a long time, often years, and I call that continuous therapy. That's usually with the BTK inhibitors. Or treatment can be for a set defined period of time. I call that fixed duration therapy. And there are reasons for offering continuous therapy to certain patients and fixed duration therapy to certain patients. And sometimes the physicians have, sometimes we'll have very strong recommendations for our patients, but sometimes it's up to the patient to decide which one appeals to them most. So these are concepts that you'll hear about more and more in the educational forum. Okay, Kaplan Meier curves. When the real doctors come later, especially Dr. Castillo, he's going to start showing you a bunch of data with a lot of Kaplan Meier curves. And what on earth is a Kaplan Meier curve? These are things that are always in our scientific publications. and they represent probabilities of something happening. And usually in cancer and in WM, what we're measuring is over here. And it might be survival, it might be how long a remission lasts, it might be when a relapse occurs, or any number of things. And what you see here is that you start at time 0, right here in this far left corner of this curve over here. And at the beginning of time 0, let's say everybody's alive and in remission. And then you treat them or you don't treat them, and you follow these patients over a long period of time, and that can be months or it can be years. And if patients have a relapse or if they die, then the curve goes this way. It starts going down. And if we cure a cancer with our treatment, the curve might go down a little bit, then it won't go down anymore. And that means that we're curing people. But if it keeps going down and down and down and down, it means, yeah, our treatment's pretty good, but with time, people are relapsing. So you'll see a lot of these curves in presentations. So usually, again, the horizontal axis is usually time in months or years. The vertical axis is the proportion of patients who are surviving or in remission. At time 0, everyone's alive or in remission. And the probability of survival in this situation, this is a totally theoretical treatment. This isn't WM. This is just a theoretical slide here. And here, the probability of survival at 2 years is 83%. The probability of survival at 11 years is about 50%. And this is called the median survival of 11 years here. So you'll see these curves again and again and again, and refer to this if you're confused later on in the forum. Here's more Oncospeak. You'll see this a lot in the slides as well. RR, response rate. The response rate is a percent of patients who've had at least a 50% reduction in the WM, the measurable WM. Usually that's determined by how far the IgM fell. So if your IgM was 10,000 and you got treated and it went to 5,000, then that's the response. That's called a partial response. And so you'll see this response rate. Sometimes you'll see it referred to as overall response rate. And response rate includes complete responses, partial responses, and very good partial responses. What's a complete response? A complete response, or CR, is when we cannot detect the WM with any of our standard tests that are available. Bone marrow biopsy, IgMs, M spikes, all that stuff. That's a complete response. That doesn't happen too often in WM. Partial response is when we have between a 50 and 90% reduction in the measurable WM. And a very good partial response is when we see a 90 to 99% reduction in measurable WM. So you'll see these referred to in the talk. So overall response rates, responses can be complete response, very good partial response, partial response. And also you'll see something called PFS mentioned during the talks. And that's progression-free survival. And that's how long patients go before a relapse or death occurs. And usually reported as a median PFS on those Kaplan Meier curves, like I showed you in the previous slide. And you'll sometimes hear about overall survival, and that's just what it says. So don't be too daunted by this. This is a pretty cool thing. This is why our treatments are getting so much better in WM. How do WM cells misbehave? And how they misbehave is stuff goes on the inside of the cell that tells the cell to misbehave and not follow the rules anymore. And those are called intracellular, in the cell signaling pathways. And this is an example of something here. This is something Dr. Treon showed just a few weeks ago at one of our meetings. And this dashed line here represents the cell on the outside. And then there's something on the inside of the dashed line, that's the nucleus, that's where the DNA hangs out. And this is the outside of the cell. And on the outside of the cell, there's all these different, they're called receptors. That's what the R stands for in these. And sometimes they turn on by themselves, and sometimes they have to get goosed or stimulated to turn on. And when they turn on, a bunch of dominoes fall inside the cell. A bunch of things happen one after the other. These things happen inside the cell. It results eventually in going to the nucleus and telling the DNA to misbehave. That's a lot how cancer works in general, and this also includes WM. So the cool thing about this is you're going to see that there's a bunch of these things we've heard about that go on inside the cell. You've heard about MYD88 right here. Right here, this is a big important guy inside the cell. There's a protein called BTK in here. And this is where the BTK inhibitors do their thing. Then you'll hear a lot about things called ERK and HAC and other things throughout the meeting that are really cool. And I think will end up being ways to treat people with WM in the future as well. So you're going to see this and explained by the people who actually did the work. So I'm going to stop at this point, and it's been a great pleasure talking to you. I hope I will make things a little more facile for you to understand what goes on for the rest of the educational forum. But it's been a great pleasure, and I'm going to turn it back over, I believe, to Lisa at this point.
Wow, Dr. Matous, thank you so much for offering that most helpful and informative summary of WM basics. I want you to know that I learn something new from you every single time I hear you teach. The basics never get old, and you offer tremendous benefit to everybody from freshly diagnosed newbies to us experienced old-timer WM patients. We are all in this together, and your teaching is truly a gift. I loved your sharing what we don't have to look at on the blood results, because it's sometimes the stuff that you don't, and you're every time you're like, I still don't know what that means. And the idea that you can ignore a number is so liberating, that we don't, every single inch and every little increment doesn't have to have a weightiness to it. We can let that go, is I find very freeing. So thank you for giving permission for that. And also that we only treat patients with symptoms can be a very hard thing for people to accept when they're newly diagnosed. Sometimes not only patients, but their family members who really want to feel like they're doing something. They're not just sitting there waiting for the cancer to get them. They're getting out in front of it, and just remembering John Waldenstrom's words of do as little as you can for as long as you can. And the best thing that we can do is nothing. If you can do nothing and get away from it, do that, get away with it, do that. So thank you for reminding us and for teaching us. And that was phenomenal. So now we have a stack of extremely thoughtful pre-submitted questions. Are you ready to answer as many as we have time for, Dr. Matous?
I think so.
Okay, let's do this. So the first question, Dr. Matous, is, it's a soft pitch. I don't have a question. I just wanted to say thanks for all you do for the worldwide WM community. I think we should all take a moment in our homes, watching from the safety of our own couches and our living rooms, to give you a huge applause. Thank you so much for that phenomenal presentation. And I want to thank this questioner for starting off with a great question. Okay. That's very thoughtful. And the second question is, why do some doctors want to start treatment right away when the patient doesn't have any symptoms? And this speaks directly to what you were just talking about, that you treat the symptoms.
Sometimes it's actually legitimate, because I have patients who don't believe they have symptoms, but they have worsening anemia over years, and their family will say, hey, you're not the same as you were before. A patient says, I'm fine. So sometimes you'll see, or you might see a patient who has kidney damage from WM. It's quite rare, and they may feel okay, but the doctor may say, I still think you need to be treated. Those are rare instances. More common is when doctors who aren't used to seeing WM as much see a really high IgM level, and the high IgM level just makes them unsettled, and they end up recommending treatment based on the IgM level, even when there aren't any symptoms. And we know in the WM world that that's not the proper way to do things. Why do they do that? I think it just comes from other monoclonal gammopathy cancers like multiple myeloma. So multiple myeloma, if we see really high levels of the antibody proteins in the blood, that almost always means the patient has a lot of myeloma, needs to be treated, that they're in danger. And so sometimes just recognizing that subtlety between myeloma and WM can be challenging for some docs.
Thank you, Dr. Matous. I know there's some follow-up questions to what you just said, so you just queued it up beautifully. This questioner asked, I'm in watch and wait mode with very few symptoms, but after a lifetime of healthy gums and teeth, I've had bleeding gums for a year and have recently lost 2 loose teeth. My periodontists have no explanations. Could these be related to my WM?
The answer is probably not, but some investigation is warranted here. And specifically, some WM patients can have an acquired bleeding disorder called acquired von Willebrand's disease. And that requires a specific blood test be drawn, a PT and something called a PTT, and sometimes a von Willebrand's panel. And the other thing to keep in mind is whether or not a patient may have amyloidosis. Sometimes amyloidosis, again, another rare complication of WM, can cause bleeding issues. Probably not related, but you can't just say that. You have to do some tests to investigate it.
Fascinating. Thank you. Ooh, this is a good one. Should I get a second opinion with a WM specialist if my local oncologist has only had a couple of WM patients previously? This is, as you know, the IWMF has the physician's directory available online, and we get this question so often because that's one of the #1 downloaded items. So what do you think about WM experts and getting that second opinion?
I'm a little biased. But I think with such a rare lymphoma that can manifest in so many different ways, and there could be some real subtleties there that maybe a physician who doesn't see so much WM may not appreciate, it's always a good idea to get a second opinion. Everyone on that WM physician list is not only used to, but enthusiastic about collaborating with the patient's local hematologist oncologist. We do it all the time. We love it. And really our mantra is any way we can help, we want to help. And so I think seeing a WM specialist for a second opinion very often is a really good idea.
I love it. Thank you for answering that so unequivocally. A lot of people hesitate because they think that they not want to hurt the feelings of their physician, or it's someone they've known for decades in their family. So it's really great to hear you say that so clearly. Very clarifying. Ooh, is there a diet that will decrease IgM? And before you answer the question, bonus points if you say it includes chocolate. That's just for me.
The answer is, we get this question a lot. The honest answer is I really don't know. And so I don't think diet can treat WM specifically, but there clearly are healthy diets that we know to be cancer-fighting diets, right? There's all kinds of really good science behind that. And the cancer-fighting diet, no surprise, is a really good healthy diet. You know, cruciferous vegetables and not a lot of processed stuff. I do include not only chocolate, but cherry pie on my cancer-fighting diet personally.
That goes really well with the baseball. Okay. Thank you, Dr. Matous. How do you know if you have the correct diagnosis for WM, i.e., what is the difference between WM and multiple myeloma?
Yeah, this used to be tricky sometimes. It's far less tricky today. For WM, again, a good pathologist who says this is LPL in the marrow and you have an IgM, that is almost all, that's going to be WM. But sometimes they waffle a little bit there. And this is where the mutational testing is extraordinarily helpful. So the MYD88 mutation, again, is found virtually in every single patient with WM, and it's not found in multiple myeloma. That MYD88 mutation is critical here. Also, in myeloma, patients often have different manifestations of their disease. They have their bones can be super irritated and sort of chipped away or eaten away at by the myeloma cells. We don't see that in WM. So those are just some examples of how we distinguish between one diagnosis and the other.
Oh, very helpful. Thank you. The cause of WM is unknown. How about related diseases like CLL, MZL, and multiple myeloma? So often we're asked the question by newly diagnosed, why and how did I get this, which is such an impossible.
Well, so it's important to point out that sometimes you can see all these diseases running through families, right? So you can see, you'll have somebody with WM, and if you look super hard, maybe in 1 in 10 WM patients, you'll find a first-degree relative, you know, an offspring, a parent, a cousin who has one of these other cancers that's mentioned on this slide here. So, but the answer to the question is, we really don't know what causes these diseases. Sometimes you can point your finger at something. You know, Agent Orange is, you know, in our Vietnam veterans is something where we'll look at those and say there's got to be a link there. But for the most part, the explanation that I give my patients is it just occurred through bad luck.
There's something liberating in that, in being able to let go of the why, and just say this is what it is, and now how do we live with it fully? So thank you for that. Many people think that stress can raise or lower IgM. Do you think this is possible?
Short answer, no. Long answer, I tell my patients all the time, whatever makes you whole, whatever keeps you in equilibrium, that's really important for dealing with cancer and fighting with cancer. So, and for some people, I say that's quitting work. For some people, it's working harder. For some people, it's cutting back on the chocolate, which I never recommend. And other people, it's doubling your chocolate intake. So whatever keeps you in equilibrium and makes you who you are, wherever you find equanimity, I think that does help cancer.
That's my favorite answer ever. Thank you for that. That was beautiful. Why is it hard to differentiate marginal zone lymphoma and WM? What are the definite markers for each? So it's a very specific question.
Yeah, and this used to be much more challenging before we knew about MYD88. So you can find MYD88 in a very small number of marginal zone lymphoma patients, but again, the MYD88, if I see it, it really points me toward WM. Sometimes there's a flow cytometry test. It's a test where you actually take the lymphoma cells and run them through a machine, and the machine can tell which specific identification tags on the outside of the lymphoma cells. Those cells are pretty good at distinguishing between these lymphomas as well, but it can be tricky. And so there are, and then the other thing that makes it complicated is some marginal zone lymphoma patients make an IgM protein just to make it even harder. And so it can be tricky, but I rely a lot on the MYD88 and a really good hematopathologist looking at all that critical pathology detail for making the diagnosis. And sometimes too, you can tell by the way the disease shows up and affects the patient. So if I have a patient who's got some low blood counts and their spleen's a little bit bigger, that might be marginal zone lymphoma.
Interesting. Ooh, this is one of my favorites. Why does it seem that WM patients are often so different from one another in their disease presentation? And Pete DeNardis, who's the current chair of the IWMF Board of Directors, taught me something so interesting when he said that when you see one WM patient, you've seen one WM patient, which speaks to our uniqueness.
It's awesome. And so it doesn't seem that way. It is that way, that patients are different one from the other. There are countless examples of this. And why is it that way? Well, whenever we think the doctors that we understand a cancer of any kind, whenever we begin to believe that, then we are in a heap of trouble, because the more we learn about cancers, the more we learn that they're different. In my presentation, remember I talked about the fact that your WM may behave differently depending on if you have the CR4 mutation or not, right? And so we see patients who have IgMs of 9,000 with no symptoms, and we see patients with IgMs of 600 with debilitating fatigue and anemia, right? And some people get cryoglobulinemia or amyloidosis and stuff. So the way I describe this to patients is not very scientific at all, but I think it makes the point. And that's cancer cells don't follow the rules. They don't follow the rules, and they can behave in any weird way that they want to.
Oh, that's great. Thank you so much. Is a PET scan necessary during initial WM diagnosis? That's a great one.
Okay, so the real answer is no, it's not, because the PET scan rarely shows very much in WM. PET scans in general tend to show more rapidly growing cancers, and they're very good at showing those rapidly growing cancers. And WM rarely is a rapidly growing cancer. So usually the PET part of it isn't terribly helpful. But patients invariably get PET scans done for a couple of reasons. One is their doc, the first time they see the abnormal protein in the blood on the M spike, the doc is thinking multiple myeloma, because that's so much more common than WM. They're thinking multiple myeloma. They do all the myeloma tests, including a PET scan. The other reason is that in many lymphomas, the PET scan is very helpful. The more aggressive lymphomas, so docs are tuned in when they see a lymphoma patient to get the PET scan. So I typically won't do a PET scan in a WM patient unless they have symptoms that make me worry about something called transformation, which is a rare event where a slow-growing lymphoma can morph or mutate into an aggressive growing lymphoma.
Thank you so much. Oh, is it necessary to have bone marrow biopsies after treatment?
So we talked about the fact that bone marrow biopsies are required to make the diagnosis. We really rarely do them afterwards. Why would we do them? Well, we have some patients who, especially younger patients, who ask me, they say, am I in complete remission? Am I in complete response? And I'll do a bone marrow on those patients sometimes. I'll also do a bone marrow if patients are having relapse disease and I don't know their mutational status. So I have so many patients that I follow who were diagnosed and had their marrows done in the era where we didn't check for MYD88 or CXCR4. So now if someone's relapsing and I think I need to have that information, then we need to do a bone marrow biopsy.
Fascinating. Thank you for that clarification. What is known and what is still unknown about the relationship between WM and pleural effusions? Please identify symptoms, treatments, and prognosis. And since I'm a WMer who has had pleural effusions, I'm particularly interested in this question.
This is a hard one. This is where I would normally look at, Maury Gertz or Jorge Castillo or Steve and say, hey, you guys want to handle this? But here's the scoop. So pleural effusion is when fluid gets trapped in the lung between the lining of the lung and the actual lung tissue. And pleural effusions can occur for a variety of reasons. And if you have these, then patients get short of breath, they get cough. Sometimes they have difficulty lying down flat to sleep at night. There's different things that can happen. And so the WM can cause pleural effusions. And the most common way it does it is when the lymphoma cells grow and either irritate the lining of the lung and cause effusions that way, or they'll grow as enlarged lymph gland tissue in the middle of the chest and obstruct the flow of lymph and other fluids through the chest when they're transiting through there. And so, and these can be pretty bothersome and symptomatic. So to treat this, invariably we have to shrink the nodal tissue and pretty aggressively treat the WM. So these are patients where more often than not, I'll go toward treatment using chemoimmunotherapy than the BTK inhibitors to get a more rapid and thorough response. And usually we can make these go away and fix them forever, usually.
Mm-hmm. Perfect. Thank you so much. I'm a watch and wait patient and would like to know the statistics on how long it might be before I need treatment. So Dr. Matous, we're asking you with this question to take out your crystal ball. Yes. Do these statistics apply to someone like me who had swollen lymph nodes at the time of diagnosis? So the $1 million question, how long?
So I've changed my tune on watch and wait. So I don't call it watch and wait anymore. I call it active surveillance. Because watch and wait means the other shoe is going to fall and you're going to get symptomatic, you're going to need treatment. Active surveillance is, I'm all over this, I'm keeping a close eye on you in case this turns into symptomatic WM. So that's the term I use with patients. And so I've adopted that phrase. So what we know is that Dr. Kyle, the godfather of WM in our country, has done some really important work looking at WM patients who have what we call the precursor phase. It's the IgM-MGUS or the smoldering Waldenstroms. And we have a pretty good idea what the risk is of those patients developing symptoms that require treatment. And for the smoldering patients, that risk is about 10% per year. But interestingly, it seems to level off after several years. And so if patients haven't developed symptomatic Waldenstroms of the first 7 or 8 or 9 years, the risk of getting symptomatic Waldenstroms actually goes down and starts to look more like the MGUS patients. Mm-hmm. And so I always tell patients that the longer you go without needing treatment, the longer you are smoldering, the longer you go. So, and then the lymph node question, I think falls into the same thing. The lymph node question doesn't sway me one way or the other, to be honest with you.
Okay. Interesting. It's not a factor. Active surveillance is brilliant. And I want to take that on and make that I want to make t-shirts and have that be our new mantra instead of watch and wait or the watch and worry. Because you, instead of waiting for it, you're doing something active, which I just think psychologically is really helpful when you're in that wonderful stage of not doing anything.
Yeah. I don't recall where I heard that. I don't recall where I heard that, Lisa. But the minute I heard that, it's like, oh my Lord, I need to change my tune here.
I love that. I love that. We got to do that for change it across the board forever. All right, we're ready for that next question. When I was 76, I was diagnosed with WM. I just turned 78. I've heard and read about the prognosis with WM. Example, I'll probably die of something else other than WM. But I assume the WM does get worse as the years go by. Can you provide a minimum of information on this subject? More importantly, where can I get information on these less cheerful facts about WM? This is, for anyone newly diagnosed, this is top of mind. So thank you to this questioner who's speaking what everybody's thinking.
You get the information at the educational forum, and you can also go to IWMF and go to past educational forums. And this has been addressed a lot in the IWMF community. So I assume this patient is smoldering, and so it reflects a little bit on what we just discussed. But the WM doesn't have to get worse as the years go by. I often tell my patients, we diagnose you in this example at age 76. You may have had this for 5 or 10 years, right? Before that, and it may not be doing anything. And so, you don't assume you're going to die of something else. And so, and I always tell my patients, I say, keep paying your mortgage, keep getting your mammogram, keep getting your colonoscopy, and go live your life. Put this in a box and periodically think about it and evaluate it. And that's the assumption you should have, that you're going to have a long, healthy life. And so that's what I tell my patients. And so, but to be scientific about it, what you do is you have to look at the literature that we have in our community, WM community, about smoldering disease and what the risks are of progression.
I love that. That is so helpful. Thank you. Because, you get that cancer diagnosis and in a minute, everything changes. But when you have WM at the same time, nothing can change.
Yeah, so the patient's perspective changes the longer they go without progressing, right? When you first get diagnosed, it's so difficult. You just don't know when this thing is going to hammer you on the head. And so, but if you can smolder for a year or 2 or 3 or 4 or 5, then it makes you feel better. And the other thing to never forget this, that if you're a smolderer and you develop symptomatic myeloma, we have phenomenal treatment that normally keeps people feeling really good and alive for a very, very long time.
I love it. I love that we didn't fulfill this question. They wanted less cheerful facts, and we didn't give it to them. We were so thank you for that cheerful ending.
Not going there.
I love it. Many people with WM like to blame every health problem on their WM. What advice do you have for those folks? I remember Carl Harrington, the past chair of the IWMF, saying in a support group, you could have a hangnail and you think, oh, it's my WM. The paper cut, it's the WM. So how do you help us out with that?
Yeah, so this is where, again, you need to go to all the educational material provided by the IWMF and be really familiar with signs and symptoms of active WM, and then realize that if it's your hangnail, you're not going to find it on the list of stuff that's caused by the WM. But in general, I'd say if you're just not sure, just ask your hematology oncology doctor. Ask the nurse. They'll know. And so, the best thing you can do is educate yourself through all the stuff that the IWMF has to offer you, and you'll figure it out pretty soon.
Wonderful. Thank you so much for that great answer. Can untreated hyperviscosity syndrome cause a stroke? Interesting.
Yes. And so if it impairs blood flow to the brain and it's severe, it could. That's I've never seen it. It would be an incredibly rare event. But poor blood flow to the brain, especially if someone has underlying atherosclerosis or hardening of the arteries, in the brain tissue, yeah.
Okay, thank you. How common are IgM lab reporting errors? My IgM was analyzed twice at a local lab and was reported at 4650 each time, which was a huge increase from 3 months ago. My IgM was then sent to Mayo Jacksonville and the result was 520. So shout out to Mayo Jacksonville. What do you think about that? I often get this question, not with such dramatic results, but with like little incremental bits, depending on what lab they're at. And people go, is this meaningful? Did my IgM change in 6 months? What does it all mean? And I'm curious what your thoughts are.
They're not common, but they definitely occur. They definitely occur. And so whenever I have a patient where I get a lab that just seems totally out of whack and not at all what we've been seeing previously, the first thing I do is I ignore it and then I repeat it, assuming my patient feels well. I mean, if someone has an IgM of 5,000 and their disease gets worse and it's 4,600, they're not going to say, hey, doc, I feel great. They're going to say, I feel horrible. What's going on? But if a patient looks and feels the same and the lab's really out of whack and the CBC, the anemias, there's no anemia or anything else going on, usually they had a problem processing the sample in the laboratory. And I've even had it done before. Well, I sent an IgM to LabCorp and one to Quest on a patient where I've seen this happening and I've called medical directors to say something's wrong with your assay. So it can happen for sure. So if you get a result that doesn't make sense, you repeat it.
Super helpful. Super helpful. Thank you for that. I would love to ask you one last question, which is my favorite question that I ask every WM expert. Would you mind doing it on the fly with me?
Let's try it.
The last one. Okay, it's the bottom of the ninth. The bases are loaded. The clock's running down. Here's the last question. What is the one thing you would like WM patients around the world to know today? If there's one thing you would want them to take away and know in this moment in time, understanding that this message could change in 3 months or 6 months, what would you want them to know and to take away and to leave this talk with?
And this is going to sound like I'm preaching to the choir a little bit, but I would say take advantage of everything that the IWMF has to offer. If you're on the IWMF and you're keeping up, then you know more than virtually the entire rest of the planet. And you may know more than many physicians. You probably will know more than many physicians about your diagnosis. So take advantage of everything IWMF has to offer.
Oh, my favorite answer of all. Dr. Matous, enormous thanks to you for sharing your time today so generously and to teach and enlighten us about WM basics and to answer so many of our questions. We got through that whole stack. I can't believe it. Every day, the work of your hands and your heart is truly a gift to our WM community across the entire globe. We benefit from your experience, your dedication, your leadership, and your signature warmth that every patient knows about and talks about. So as always, you hit it out of the park today, Doctor. Thanks for another home run. We're so grateful to you.
It's always a pleasure. I'm very honored to be able to help.
Thanks, Dr. Matous. On behalf of the IWMF, I'd like to thank our generous EdForum sponsors, Beijing, Selectar Biosciences, Pharmacyclics, Janssen, and X4 Pharmaceuticals. And to all of you watching at home, we are extremely grateful to you for being with us and hope that you enjoyed today's program. Don't miss the WM and self-care workshop that's going to be held on October 13th and our 2 EdForum days on October 28th and 29th. There's more fun learning and warm connections to be made virtually throughout this entire month. So remember, with the IWMF, you are never alone. We'll see you soon, and thanks again, Dr. Matous.